I understand that the topic was a little interesting, if a bit vague. Dr. Lohanathan asked me, is that correct? Grammatically correct? I said, yes, it is grammatically correct. So the reason I'll just tell you why we chose this topic. It's nothing complicated. It is just that these children who are born with abnormal head shapes, okay, obviously God had his day off that day. So in a perfect world, all children will be born like this, and if towers are built, there won't be a 9/11. Unfortunately, it doesn't happen that way. So children are born like this. Aeroplanes do hit the towers, and so life is not always fair. So today I'm going to talk about craniosynostosis, these unfortunate children who are born with severe abnormal head shapes with mental retardation, raised ICP, and various other complications. So I'll give a brief overview of what is craniosynostosis and then speak about our experience, what we have done over the last 20 years. So this is nothing new. Craniosynosis was reported in ancient Egypt, and this is one of those terracotta figures which was there from the time of ancient Egypt in, where else? The British Museum, where anything before the last century always accumulated in the British Museum. Now this is a picture of Queen Nefertiti. So as you can see that she has got a lovely long, very slender neck, but more important to us is this shape. Those days this was considered fashionable. So people deliberately made the head shape go abnormal according to the fashion of the day. So sometimes you get this accidentally, but sometimes it is deliberate. So when do you get it accidentally? If a baby lies on the side, then it becomes positional craniosynostosis. Always lying on one side, then you'll get that side compressed, and it looks flat on that side and bulging on the other. So these things which are positional in nature can be easily treated by simply changing the position of the child and teaching the parents how to manage that. But sometimes these things are produced intentionally in what is called as a cradle board. Now, in the South American tribes, they used to carry the children to work like this. So you can see that this upper part of the board is compressing on the forehead like that. When that prolonged like that, when the child is only a few months old, as you know, the skull is very malleable at that age, and the child ends up having an abnormal head. So sometimes they tie bands to make the head to the desired shape. Now these are some of the fashions. This is not in South America or Egypt, but this is in Paris, France, where in the last century this was considered very fashionable to have a head shape like that. Okay, coming to the modern era, these are the landmark names who worked on craniosynostosis. Starting with Virchow, who postulated how it started. Tessier was a very famous French neurosurgeon. Hoffman and more. Lefort, all of you are familiar with Lefort's fractures. So facio-maxillary surgeon who also contributed a lot to craniosynostosis. And Markek and Rainier will come to that later. So what is craniosynostosis? Craniosynostosis is defined as the premature closure of a cranial suture or sutures leading to alterations in head shape. So the sutures must close prematurely. That is a fundamental requirement. Now the incidence is about 1 in 2000. 10 to 20% are Mendelian. That means they are inherited. But isolated cases are much more common, forming about 80% of the incidence. So look a little bit about the skull development. If you look at it, the skull has got a viscerocranium or a facial skeleton and a neurocranium. The neurocranium is again divided into, this is the skull vault and this is the skull base. So both these are very, very important in the development of craniosynostosis. In the vault, the bone formation is intramembranous, and in the base it is endochondral. Now if you look a little bit, this whole thing, the craniosynostosis is based on the suture. So it's important to know what a suture is. A suture is the joining together of two bones. As you know, the skull is not a single bone, but it's made up of number of bones which are joined together in places called sutures. Now, the suture starts in what is called as the ectomeninx, and it gradually ossifies. Some of them just join together and meet each other. They don't overlap, but some of them overlap, especially the parent bones. The single end-to-end is in the single midline, like the sagittal suture is single suture. So here it is end-to-end, while the paired sutures, that is the coronal suture and the lambdoid sutures, are paired sutures. So there they overlap. Now, the whole basis of craniosynostosis and its management is dependent on this one sentence. The infant skull enlarges in response to the growth of the underlying brain. So this is very important. Unless the brain grows, the skull does not expand. Very, very fundamental. So for a good normal shape of the skull, you must have good, even, symmetrical brain development. This is very, very important. Now, 50% of the adult size is achieved by the age of 6 months, and 80% of adult size by 2 years. So this is again very important. After 2 years, the brain growth size becomes very less. So all the growth happens before 2 years. So if you want to do any management, it has to be before 2 years, ideally at the age of 1 year. Okay. Now, a normal suture closure, when does it occur? The normal closure occurs secondary to the loss of forces of separation. So this is the corollary of what I told you previously. So when the brain expands, the skull expands. If the brain stops growing, the skull stops growing. Basically, it's as simple as that. Now, when the skull stops growing, when the brain stops growing, the skull doesn't grow. Only when the skull grows, the sutures can separate. Otherwise, what happens? If there is no underlying pressure of increasing the skull, separating the skull, then the sutures fuse. So this is the basis of craniosynostosis. So in the cranium, it fuses around 12 to 14 years, and in the face, it goes on till adults. Now, what are the main reasons? As I told you, majority are isolated. We don't know the reason. But 20% are genetic. So we look a little bit about the genetics. So the main reason is we don't know for unknown developmental reasons. Then premature closure of suture is due to lack of underlying brain growth that ordinarily causes the suture to remain separated. Then mechanical compaction. Suppose in the uterus there are twins or triplets. They all compress each other because of lack of space. That sometimes gives rise to compression from outside, which can produce fusion of the suture. Then premature fusion related to metabolic disorders. So these are all causes of craniosynostosis. Now, little bit about the genetics. So loss of chromosome 7 and chromosome 10 can lead to craniosynostosis, especially the syndromic Cruzon syndrome. So regulatory genes called homeobox genes control craniomorphogenesis. So one of the most important development of genetics in stenosis is the discovery that all these cranial synostotic syndromes are caused by fibroblast growth factor receptor system, which has 3 of them, and changes in these genes cause craniosynostosis. So this is various syndromes which are caused by various genes. So how do you classify craniosynostosis? Morphological, according to the shape, you can classify as dolichocephaly or brachycephaly, depending on the shape. We'll come to that later. Primarily, otherwise it can be classified as syndromic and non-syndromic. So syndromes are Cruzon syndrome, Apert syndrome, various syndromes are there where there is a number of factors involved both in the skull as well as in the body, which gives rise to different syndromes. Then secondary mechanical, as I told you, external pressure. Metabolic, lot of metabolic factors can produce altered skull shape and of course failure of brain growth. So metabolic, hyperthyroidism, rickets, hypercalcemia, mucopolysaccharidosis, all of them cause altered skull shape. Hematologic, thalassemia, sickle cell anemia, polycythemia vera. Then iatrogenic. Now, if a child undergoes BP shunt for hydrocephalus, the child comes with a big head, but when you operate and remove the CSF, you can find that the skull size becomes smaller than normal. So that is, especially if there is overdraining of the CSF. So that can again lead to microcephaly. Then teratogenic. So what are the general theories? The suture is the primary site of the abnormality. So as you know, the skull vault contains a lot of sutures, and it's the sutural abnormality that causes the problem. The second theory was that it's not only the suture, but the skull base. The primary problem lies in the endochondral development of the skull base, and that is what initiates the changes in the suture. The third theory was that it's a combination of both. Then again, how can you predict what suture will produce what shape? Yes. So each suture, if there is a fusion of coronal suture, it will produce one shape. If there is a fusion of sagittal suture, it will produce another shape. And that can be predicted by this Virchow's principle. Growth is restricted to the plane perpendicular to the fused suture and enhanced parallel to it. So suppose you have a sagittal suture from front to back, then the growth is parallel to that. So that is why the anteroposterior diameter of the skull becomes more in sagittal suture synostosis, while the opposite is in coronal. In coronal, there is a biparietal diameter widening. However, it's not as simple as that. It's not just one suture parallel growth, contralateral growth is not as simple as that. There are multiple other factors, and there is increased compensatory growth on other sutures. So let us look at the suture. So as you all know, this is the sagittal suture in the midline. It's a single suture. Then you have two coronal sutures. You have the metopic suture on the forehead, and then you have the paired lambdoid sutures here, and then the sphenopalatine sutures are there in the side, which are not that important. So for our discussion, the primary sutures will be metopic, coronal, and lambdoid. Funnily enough, for even over 20 years, we have not had a single suture of lambdoid which we had to operate. So in metopic suture, you will get a trigonocephaly. In sagittal, you will get dolichocephaly. In a unilateral coronal, you will get plagiocephaly. If there is bilateral coronal or lambdoid, you will get a brachycephaly. So if it's unilateral, it's called plagiocephaly. If it's bilateral coronal fusion, it's called brachycephaly. So what are the neurological features? They are very common in syndromic craniosynostosis. Isolated craniosynostosis generally do not have much of neurological deficit. So what are the changes you can see? Obviously, the first one is a skull deformity. Then you can have a small percentage have mental retardation, which is much more common in syndromic. Then raised intracranial pressure, hydrocephalus, cranial nerve dysfunction, and associated anomalies. So how to evaluate? So first you have to look at the head shape. The patient comes to you because they find that something is not normal. Then you have to feel for the sutures. So if the suture is fused, you can actually feel it, and there is a ridge which you can feel. Then look at the level of the ears, especially in plagiocephaly. You can diagnose whether it is sutural or non-sutural by looking at the shape of the ear and the position of the ear. A good neurological examination and extracranial features like syndactyly, all of that you have to evaluate to see which syndrome the child belongs to. So this is anterior plagiocephaly or unilateral coronal fusion. So here you will find that the ears are asymmetric. Then here you can find what is called as the quizzical sign or harlequin sign, where one eyebrow goes above as if the child is questioning something all the time. Some cases are doubtful. Of course, in neurology, nothing is black and white. So you get children who come where there is a slight abnormal head shape, and then you take the X-ray or CT scan, and then you find that the suture is normal. So that head shape need not be corrected. So you have to be careful about your choice of cases. Look at this boy. He came to me with head shape because there was a biparietal diameter was increased, but sutures were normal, so we just followed him, and it finally developed into a normal head shape. So mental retardation is more common in syndromic. With one suture, the incidence is about 2.5 to 5%. In syndromic, it is much more common. Raised ICP, as you know, the normal ICP is 5 to 15 millimeters. Pressure can be raised due to reduced venous drainage, increase in CSF. Symptoms include headache, vomiting, and head size may increase. And if AF is open, it may be full or tense. This, if not treated, will lead to papilledema and optic atrophy. Okay, this is the same thing. Now, okay, this is a classic. I don't know how many people have seen. We hardly ever see this picture now. This is a X-ray of a child with raised ICP. what is called as the copper or silver beaten appearance, because when we go on to CT scan straight away. Then hydrocephalus again is highest in cruisons, and it's due to basal cistern block or aqueduct stenosis. In our experience, out of 74 cases, the incidence of hydrocephalus was only 2, for which we did a VP shunt. Cranial nerves can be involved, and if you are not careful, optic atrophy can occur when there is raised intracranial pressure. So, a little bit about our experience. I started this procedure here in 2002 after I went for training in UK, and then over the last period of about 20 years we've been doing. The number of cases are not that great because people are not referred, because most of them are missed during the early childhood. So we saw about 112, out of which we operated 74 cases. There were doubtful cases were 8. The deformational, this is important because lot of times if it is just deformational, it doesn't need any surgery. So we have operated 74 cases from the age group of 3 months to 1.5 years. One case we operated at the age of 6 years. Now, the age of operation is important because the child generally comes to us when it is about 7 or 8 months old, and the period of early intervention is gone. So the next early intervention can be done at the age of 1 year. 1 year because it's a compromise. Now, when you do a vault reconstruction, there is a lot of blood loss, and the child should be able to withstand that. So, at the same time, if you allow too much age to go, the skull becomes very thick. Then it's difficult to mold it. So, a compromise is reached where the child can withstand the surgery. At the same time, the skull is malleable enough for us to shape it. That is approximately around 1 year, maybe around 11 months to 13 months is the ideal time, though we do operate at other periods also. So we have done about 40 cases of sagittal, 19 coronal, metopic 10, and multiple sutures. You can have more than one suture craniosynostosis also. Then recently we started to do endoscopic repair instead of doing a full cranial vault reconstruction. I'll come to that later. So age at surgery, less than 6 months 5 cases, 10 to 12 months 65 cases, and more than 12 months 4 cases. So why at 1 year? I've just told you. This we have seen. So again, this is the X-ray, and the primary investigation is a CT scan with 3D reconstruction of the skull. It's very important we do a 3D reconstruction because otherwise sutures cannot be made out clearly. CT scan has revolutionized craniosynostosis surgery. As you can see that this is the normal suture, coronal, metopic, and sagittal. And here you can find that you can't see the sagittal suture. You can see the other sutures, but sagittal suture is not seen. So this is a classic case of sagittal synostosis, and you can see that the skull shape is like a boat. It's either boat shape or elongated anteroposteriorly and is called as dolichocephaly. This is a scan of a child with trigonocephaly. Trigonocephaly, as the name indicates, is triangle in shape. So you can see classically this is metopic suture fusion, triangular shape, and this is how the skull looks. Another big advantage of 3D CT is you can see inside the skull how it is, the base of the skull, and you can see the typical triangular face. That if you don't increase the volume of the skull, that can lead to reduced mental development later on. So the primary indication for doing surgery is to enable brain expansion and relief of intracranial tension. Of course, improvement in function comes secondary to that, and cosmetic and psychological. If a child has an abnormal head shape and goes to school, the child will definitely be ragged and develop psychological problems. But the cosmetic part of it is always secondary. The primary is to prevent future brain development, or rather prevention, increase brain development. So here is a child with a sagittal synostosis which we have operated, and this is how the child looks at the end. You can see that there is an enlargement dolichocephaly that has been corrected. Another important thing is you have to explain to the patient that all we are doing is we are removing the barrier for proper development. We are not doing a final corrective surgery. So the end of surgery, the child will not look normal. This is very important. All we are doing is to enable the normal brain to expand and produce the proper shape. So it will take about a year or two before the final shape comes in. So at the end of surgery, parents will think that, oh, modali ipdi irundhathu, ipo ipdi irukku. So you have to explain very clearly that the child will look almost the same at the end of surgery, except in trigonocephaly there will be a marked difference. Others, there will be remain almost the same. So this is how we do it. So this is called cranial vault reconstruction. Now what we do is, we do a bicoronal flap, then we move the flap both anterior and posterior, exposing practically the entire skull. This is a case of dolichocephaly. So here you make, we break the bones up. That's all we do, simply. So we break the bones up and we do what is called as barrel stave. That means we cut the bones into not pieces, 3/4 of the bone we cut so that it becomes more malleable. So a stiff bone becomes more malleable, allowing the brain to push from inside. So this is how it looks at the end, and then all the bones that we break, we put together and we stitch it so that the anteroposterior diameter in dolichocephaly is reduced, and because you do a suturectomy, the biparietal diameter will increase further. Here is bicoronal fusion. So look at this child. This child has got bicoronal fusion, proptosis, and this is the case of brachycephaly, and we have done about 9 cases. So what we do here is slightly different. We do a bifrontal craniotomy. We take what is called as an orbital bandeau. That means we separate this bone from the skull. We cut through here and here, cut the orbit above, and this bandeau is taken as a separate one. Then the bifrontal bone is taken separately. Then this whole orbit is advanced. That bandeau is advanced because we want to increase the anteroposterior diameter. So we want to make the skull come forward, the skull wall. And then once we advance it, then we fix it. So this is how it's done. Child is present, we do a bifrontal craniotomy. Then this part of the thing you can see here is separated. And that is moved, kept an inch forward and stitched in place. And now of course we have what is called bioabsorbable plates. We put bioabsorbable plate and fix it in the new position. So this is a case of anterior plagiocephaly. You can see that there is an asymmetry here. One side there is a frontal bossing, the other side it has gone down. So we have done 9 cases of anterior plagiocephaly, 2 cases at hydrocephalus and BP shunt. And this is where we do, some people do only unilateral frontal craniotomy, but some people do bilateral also to make it more symmetrical. Trigonocephaly. This is again very, very gratifying to operate because the child looks very abnormal when they come, and what we do is we make a cut here, again we make an orbital bandeau, we advance it, and then we make the skull flat. So we cut it in the middle, the orbital bandeau is made flat and fixed in place. So this is one of our cases where there is a classical trigonocephaly. The scan looks like this, and this is the post-op patient. You can see completely the triangle has gone. So this is how it looks at the end of surgery. Still a little bit of triangle is left, but as the child grows, you can see that it is correcting itself. What are our complications? Luckily for us, and I must thank the anesthesia team starting from Dr. Vasishta, who was there with us for several years, who did all these cases, and then when Dr. Prabha took over, she has been doing that, and we have not ventilated a single case. In the last 20 years, we did not need to ventilate a single case post-op. All of them were extubated. We had nil mortality, nil infection, and nil airway problems. And so the anesthesia team and the post-op pediatric ICU team, we're all very, very crucial in how we get the good results. Late complications, we've had 3 cases where there was one child who was overactive. Children now are extremely overactive. The boy went, hit against the cot and then broke the bandeau, but luckily it was not displaced. So we let it go and it healed well. The one child had a CSF collection. So when you do that, you will find that the dura is stuck to the bone very much, and you have to carefully dissect it, and you can get a CSF leak. So team approach is very, very important. So what is new? Now we can do it endoscopically, but we need to catch the child at 3 months. So if you catch the child between 3 and 4 months, you can do endoscopic surgery only for selective cases. If you do that, then this is a child we did with a sagittal synostosis, and this is how the incision, see, for the previous one was such a big incision. This is only a 1-inch incision, and there is less blood loss, time is less, and cosmetically better. This is an operative video, I'll skip. So you can see the scar, how it is. And this is the child post-op after 1.5 years. And you can see the difference in the scar. This is so much and this is so much. So if you can get it, the only requirement is that you need a proper helmet post-op. Unfortunately, we don't have that kind of helmet making ability here. So that is one reason why we don't do all the cases at 3 months. Because without a helmet, it doesn't help much. So the take-home message is early diagnosis and surgery. Thank you very much.
Thank you, Dr. Murthy, for an excellent talk. Just, I'd like to have one comment. The thing is, talking about brain growth and skull growth. The brain is not growing because the skull is not expanding because brain is
not growing.
Growth is arrested. The other way, even if the skull is expanding after the surgery, just this brain growth becomes normal and the mental growth.
Yeah. If we
functions after the surgery.
If we intervene early enough, that is at the age of 1 and maximum at the age of 2, brain growth is normal. Except in syndromic cases, that is an underlying brain deformity that doesn't help. But in patients with isolated craniosynostosis, brain development becomes normal if we operate at the correct age. Now, the secondary craniosynostosis is the one where stenosis, where if you have an infection, say during pregnancy, and there is loss of brain matter, then that expansion becomes less. So it develops microcephaly. There, surgery will not help. So you have to distinguish between secondary microcephaly and primary craniosynostosis.
Good morning, everyone. First, I would like to thank the management and for giving me the opportunity. Thank Asokan sir for giving me the opportunity to talk about acute stroke intervention in this forum. So, first in stroke, every year October 29th, Stroke Day is observing the Stroke Day, and October month is a Stroke Awareness Month. So, as a part of that one, we are talking about acute stroke intervention, what we are doing in our hospital. So, what is stroke? It's just like heart attack. Everybody know about heart attack. Like it is called brain attack, but nobody say it as a brain attack. It's called stroke. So why it is important? So why it is important? First, we have to recognize stroke signs and symptoms. So that is simply we call it as B fast. B fast means what is B for balance loss? We have to recognize all these things. E for eyesight loss, and F facial drooping, and arm weakness, speech difficulty. Then it is time to call the emergency services. So delaying stroke recognition will cause profound damage to the patient brain. So why it is every minute? So delaying recognition of stroke, delaying for every minute. If your patient is coming to emergency and recognition of stroke is important, and if we delay for 1 minute, we lost 2 million neurons. 1 million is 10 lakh. 10 lakh. So 2 million means 20 lakh neurons will die in every minute. So the patient brain ages by 3.6 years for every hours. So stroke, two types of stroke occurs. One is ischemic stroke, another is hemorrhagic stroke. So recognition both is important because management is totally different. Hemorrhagic stroke, there is no intervention, but it's large conservative management and controlling the BP. If it is large hemorrhage, then surgical evacuation, abdominal care. Ischemic stroke, it is occlusion of the blood vessels. That brain is supplied with both carotid and vertebral artery, and the intracranial circulation, anterior cerebral artery and middle cerebral artery. Posteriorly, that is vertebro-basilar artery. These are the important arteries supplying the brain, and when it can occlude it. So one is cardioembolic stroke. Some patient with cardiac issues, sometimes embolus can come and embolus can detach and it can go and occlude either middle cerebral artery, ICA, or basilar artery. That is ischemic stroke. Another thing is in situ occlusion of the intracranial arteries. In the Asian population, intracranial atherosclerotic disease is very common. Compared to the Western population, it is very common. 25 to 50% of patients with ischemic stroke, that is occlusion in the middle cerebral artery or basilar artery, in our Asian population will have underlying atherosclerotic disease. So in our practice, we are encountering a lot of patients with intracranial ICAT disease. We call it this ICAT, intracranial atherosclerotic disease, ICAT stroke. So we have to reach. So once even patient or your relative, whatever, whoever patient develops stroke, they have to immediately reach the right hospital. Right hospital means the every facility should be available. So from emergency services, then imaging services, and 24 hours availability of neurologists, central radiologists, neurosurgeons, everybody should be available. So we have to reach. Our hospital is advanced. We got. With our sponsor effort and our hospital management, we got the approval of advanced stroke center in the last month. And so once we reach emergency, so emergency physician will assess the patient, and if they diagnose it is a stroke, then immediately basic blood investigation and imaging will be done. So this is a graphic image. You can see the central red part is the infected region. The surrounding green part, it is a still viable parenchyma, but still it is in ischemic region, ischemic area. So if we immediately intervene, we can save that brain parenchyma. If we delay for 6 hours, you can see that core volume, that is infected core volume, is increasing, and the penumbra, that green area, also increasing. If you don't intervene by this 6 hours, the entire area will go. So patient will permanently become hemiplegic. So, emergency physician, emergency staff will assess the NIH score, National Institute of Health stroke scale. That is, minor stroke score will be 1 to 4, and moderate stroke score will be 5 to 15, and severe stroke above 16, and very severe stroke is 21 to 42. So, how to manage? So, once we reach emergency, as I said, blood investigation, then imaging will be done. Whether CT, MRI, we follow MRI stroke protocol, basic blood diffusion method, FLAIR image, and MR angio we will do it. So why we are doing? So we have to note hemorrhage, and we have to identify how much infarct size has occurred, whether IV thrombolysis can be done or endovascular mechanical thrombectomy should be done. So this is the IV thrombolysis up to 4.4.5 hours. We can do it. If there is no, first we will do hemorrhage. If there is no hemorrhage, if this is not a large infarct, we can do IV thrombolysis. So this next is beyond the window period. If patient comes, then we will assess whether patient is candidate for mechanical thrombectomy. Here, what we will use a stent. It's a stent is a small metal mesh kind of thing attached with a large string of wire. We will insert through the femoral artery, and we will retrieve the clot. So mechanical thrombectomy up to 6 hours is ideal. Once we reach a hospital, and within 6 hours we have to puncture the femoral artery. Sometimes in selective patient, up to 24 hours also we have to do. In posterior circulation, up to 24 hours we can do, because basilar artery occlusion almost always it is end up in patient mortality is very high. So up to 24 hours we can intervene. So this is a small graphic video.
This animation shows a man and then breaks off and plugs up one of the main arteries, dying nutrients. Situations like this, we can intervene. We can go in from the femoral artery in the leg with a catheter, as you see here, place it.
So this is a femoral artery. We will take a small catheter. This is an internal carotid artery. You can see the clot occluding in the middle cerebral artery. That is a proximal M1 segment. So we will use some multiple tubes. We will keep one tube in the carotid artery, another tube in the petrous or paraclinite segment. Then we will small tube. That is a less than 1 millimeter small wire. We will cross the clot. Then over that one, we will take a small tube. That is a 1.5 French tube. Even 1 French is 0.3. It's a 0.5 millimeter tube. We will cross that clot. Then we will place the stent within that. I showed that image. That's the stent. We will deploy across that artery.
Stent-like device that we unsheath.
Then we will remove the tube. So once we remove the tube, automatically that stent will expand. It will capture the clot. This is a embolic clot, so it will be easier to remove it. But in what I already said, intracranial atherosclerotic disease, that will be having like a coronary artery disease. Plaque rupture and clot will be there. This is simple embolic clot, so we can easily retrieve the clot. These cases we can done it in 20 minutes, 15-20 minutes, it will be over.
And the carotid artery in the neck, which arrests flow, And
This
then
is balloon expander to arrest the blood flow. Then we will aspirate and we will remove the clot.
Decided into that balloon cap. This animation shows how we perform stroke intervention.
So next I also few cases. This is a 25-year-old female patient. She developed slurring of speech and left hemiplegia. Power is 0. Okay. She is a known rheumatic heart disease patient, and CT, that time CT was emergency CT was done, and it showed M1 occlusion. So this is a CT. So you can see it is a plain CT. You can see the hypertension MCA. There is no major infarct. You can see small hypertension in the external capsule region, no hemorrhage. This is the CT angiogram. You can see this is the left middle cerebral artery. You can nicely see. You can see the abrupt cutoff of the left middle cerebral, right middle cerebral artery. So it's a hyperacute stroke. This is the image of the patient. You can see no flow in the. It's a clot occluded in the M1 segment. Still, it's distal middle cerebral artery branches were seeing filling with contrast because of the collateral supply from the anterior cerebral artery. So you can see that this is then we immediately have taken up the patient for angio. You can see right middle cerebral abrupt cutoff. There is no blood vessel is seen here. You can see the delayed sequence. You can see the anterior cerebral artery collateral supplying this area. So if you open this, still this area is a viable area. If you open up this middle cerebral artery, this area will escape. If you don't open it, the patient will develop large massive infarct, middle cerebral artery infarct. So we placed that stent retriever. We use solitaire or embotrop. These are different stent we use. We placed here. You can see the marker here, and here this is a stent across that occluded middle cerebral artery. Once you open up, you can see the nicely opened up middle cerebral artery. We completely opened everything. So at the time of discharge, patient power was normal, and the patient underwent mitral valvolectomy after 3 weeks. Dr. T.R.M. sir only did that case. Second case is a 49-year-old rheumatic heart disease patient post balloon valvolectomy done. Dr. Balaji patient. Patient is from Ooty. She developed a weakness on the left upper and lower limb from morning 9 a.m. She reached the hospital by 2:50. So patient power was 0 and the NHS score, that is a severe stroke more than 15. It means large vessel occlusion. So CT brain and angio was done. Then echo also done. No clot in the LA. This is CT brain. Sorry for the poor quality. You can see that this patient also had a right M1 occlusion. These are the collateral supply. That's why she reached the hospital after 6 hours. Still that area is viable. So we did a mechanical therapy again, CT angio, abrupt cutoff of M1 middle cerebral artery. This is on the table before procedure. I told her to lift her both upper and lower limb. You can see the right upper limb she is lifting, left upper limb there is 0 power. Right middle cerebral artery, occlusion, so left 0 power. So we did angio, right M1 occlusion. So you can see the no blood vessel is seen here. This is the solitary. You can see the stent captured that clot. These are the clot we removed. This is after opening, middle cerebral normal blood flow is established. You can see a lot of blood vessel here. This is immediately after table. You can see that this is cath lab table only. Okay, after immediate she was able to lift both upper and lower limb, normal power. So because of the collaterals, that brain was still viable. So once you open, it again she regained her normal power. This is a 42-year-old male patient, sudden right limb weakness, swelling of for 5 hours, and upper limb power 0, lower limb 3/5. MRI done outside MC. In fact, patient was drowsy and arousable. So you can see this is a tapered middle. Tapered means it's a gradual narrowing of the middle cerebral artery. It means he may be having underlying stenosis. So we expected he may have underlying stenosis. So we did again thrombectomy. We still placed a stent. You can see this one stent. After removal, you can see the underlying stenosis. Like embolic stenosis, normally now you will see the normal caliber of the vessel. Here you can see the tapered and narrowing it. Immediately after removal, 5 minutes check angio. We used to do repeat check angio after 5 minutes. You can see it's completely again occluded. So 2-3 times we were done, re-occluded. So finally we did plastic for that patient. Balloon deltas in the middle cerebral artery. Still residual stenosis is there. Finally we end up in putting coronary stent. You can see that after placing the stent. This is the stent you can see. This is acute stenting in the coronary acute stroke patient using coronary stent. This is the stent. No hemorrhage. Patient power improved to 4/5 and he was on 12 antiplatelet. This is a 37-year-old patient and weakness in the right limb. He is drowsy, reached emergency by 9 a.m. drowsy, not responding, power is 0. He is a known polycythemic patient. He had already low limb DVT on acetrom. but he's not. He's our old CT technician. Many of you know about him. He's not on regular treatment. MRI showed occlusion of left ICA up to MCA bifurcation, long segment occlusion. See, this is the when he was in the CT room. He was intubated, drowsy. This is a large infarct in the middle cerebral, the basal ganglia. You can see here large infarct. So this is the right and internal carotid artery. You don't see any carotid artery here, right? Internal carotid artery, MCA, nothing is seen. You have abrupt cut off from the left ICA origin itself. So this is in external carotid artery, ICA, MCA, nothing is seen. Previous cases only middle cerebral occlusion. This is both ICA and middle cerebral artery. So we aspirate all the clot from the ICA up to paracranial segment. Then we placed a stent in the middle cerebral artery. These are the clot we aspirated from the internal carotid artery. So we opened up the ICA, then still the MCA clot is there. Then we placed a stent and removed the clot also. This is you can see the stent captured the clot in the middle cerebral artery. These are the clot in the middle. So finally, this is a residual small adherent clot. We put him on heparin and ecosprin. These are the contrast staining. This is not hemorrhage. Infarct region, blood-brain barrier will be disrupted. So contrast, injected contrast will stain that area. Next day we did CT. Again ICA occluded, but he had a good ACOM. So cross circulation was there. So no further progress of the infarct. So at the time of discharge, his upper limb power was 1. He was conscious. Power was 1. Lower limb power was 2. 3 months later, he was walking without support. Speech was normal. See at the time of discharge. Thank you, Asagan sir, for giving the images. This is 2 years later. I asked him to send down a video of him. I called him. Just I want to show your video. This is 2 years after. Right now he is in Vellore. I called him to send the video. He sent the video. He was able to walk and do this thing. Still, he is having some poor hand grip and all this thing. This is a last patient. This is a 52-year-old male patient. Sudden left upper limb weakness and angle of mouth deviation 3 days back. So to start on a dual antiplatelet. So he was referred to my OPD for some to evaluation. OPD itself, when I was seeing, he has developed a slurring of speech. So immediately we admitted him and did CT angio. And this is see old infarct in the right thalamus and the left cerebellum region, posterior circulation stroke. So CT you can see tight focal stenosis in the proximal basilar artery. So though he is on dual antiplatelet for last 3 days and he developed a stroke, so we advised him, we plan to do intervention. So very tight 99% stenosis of the basilar artery. So we took him for angio, vertebral artery injection. You can see that it's the same thing, stenosis. So we we did plasty and stenting for him. This is stenting after stenting. This is after stenting. You can see nicely opened up. So he was recovered. So timely recognition important. He was lucky that he was in OPD and immediately discussed and took him for angio.
Really fast. All those things. Balance, CPI, this base group. A is on drift, the S is sweet, and T is time to act. The time to balance. So as early as possible. Still over 1 hour. As soon as you get the patient, the emergency. In hours time, that evaluation and before 1 hour, we should be able to lice the patient. Okay, and the total time allowed by this now for 4 hours. So if you exceed the window period, but still your CT angio or small angio shows small infarct, large. That is 4 infarct is small, but surrounding phenomena is small. What is phenomena? Phenomena is an area where the supply is reduced, but still there is a viable issue. If you can put in blood supply back to that area, it becomes live. The central area is dead area. Once the score is a dead area. To prevent the expansion of the dead area, we are doing all this. So if you can put back the supply, it's called revascularization. If you could revascularize the area, as it is possible, okay, now you have crossed the before and was hard before and was the patient. What are you going to do? You can do that's what you can ask the patient and look for the penumbra, the core area, the core is small, penumbra is large, and if there is LVO, largest occlusion, by which we mean M1 approach or IC approach to breast factor. This thing, M1 IC breast factor. If it is there, then you can take one for from that. Of course, the window period we say is up to 6 hours. But if the periphery, in the periphery, leftover meningeal muscles, you could make out some vessels, large phenomena, you can go up to 20 hours without wasting time. So really you can revascularize the tissue and you can minimize the maximum deficit and gives, rather than give life back to the patient. That's the idea of doing normalization of. So thank you, Dr. Kore.
Thank you.
So any doubts?
Mentioned it as a key effort for our greatest hospitals. It is the future value. First, acknowledge that you can classics and university meet for all the cases that we have done in our hospital and must know the teamwork, pediatrician, anesthetist, and ESQP, everybody is part of it. I forgot to mention that.
Dr. Uttarajan is our magician. He really does magic when we are. But what are the chances for mortality in this procedure? And what will happen if you do not intervene? Will all these phenomena go in for non-functioning or spontaneous recovery? What is the percentage with your intervention and without your intervention?
The largest representation for this they will end up in alternative representation alternative because patient will go patient will go to the there is some part of the occlusion, if you don't open it, complete bowel is closed. So it will be better than the heart. So if you open up and after assessing the CT of my still viable it has. Now it's viable. This came great, but still viable. To open it up, then we can save the data, the patient. So mortality is a procedure related is 25% because we are going to open mainly we are going to probe the uploaded muscle file. Some days file can calculate, really can happen. So 5% is number. And if we don't open, if we don't take the risk, then patient will lose the patient. Large impact patient will have loss effect. They will panic. So let us take the risk. Very good.
This intervention neurology is really revolutionized the management of stroke and aneurysms, especially for brains of stroke. Patient would be a no answer. If patient had a vertebral artery or brainstem occlusion, completely there is no answer. You would have lost them. 99% you would have lost them. Now after this intervention, showing the specific so many cases, it's really unbelievable. And patient after 1 month is walking home. This was never seen 5 years ago. And I think it's a fantastic
Thank you very much. And I take this opportunity to talk for the stroke, it's called the comprehensive stroke therapy under one roof. We are going to talk and we are going to give a lecture. This will be on 16th November at the Golden Park Hotel. All of you are invited. If you could find out time and if you are present and will be honored. Thank you. So, we make you all.